All right, folks. Well, this is actually a special episode of Healthcare Unfiltered because it focuses on so many things and that we are going to tackle in 1 hour. But really, the large theme of this is basically I was on Twitter and I see a bunch of guys on a mountain somewhere, and they weren't necessarily bragging about being on top of the mountain. They actually were talking about seeing patients in a clinic and doing from ultrasounds to x-rays to stethoscopes, and I was really intrigued. And among those guys is one of my frequent guests, Dr. Saurabh Jha. So I reached out and I thought, you know what, let's just understand what happened in that trip and discuss global medicine and medicine really outside of the US, with a little bit of a twist on diagnostics and x-ray and imaging. So with that, I have two phenomenal guests that were on that trip that really intrigued me and piqued my interest. And I'm going to have them introduce themselves first, and then what they do, who they are, and how did you both meet? So Saurabh, we'll start with you. You're in the great state of Pennsylvania. Tell us a little bit about you. And I understand that one of your claims of fame, you're the first Indian general radiologist, something like that.
Thank you, Charlie, for having us. Yeah, I'm a radiologist from Philadelphia. And as you know, we decided not to elect Dr. Oz. So we're all about, real allopathic treatment, not homeopathic treatment. So I, amongst other things, I am a global radiology enthusiast and also a person who writes about many things, including artificial intelligence.
It's great to see you, and I love the political twist right there. Prashant.
Hi, Charlie. Great to be here, and thanks for inviting me to talk about our journey to the Mount Everest Base Camp. My name is Prashant Warier. I am co-founder and CEO of Qure AI. We are a 6-year-old AI in radiology company focused on interpreting X-rays, chest X-rays and musculoskeletal X-rays, and CTs, chest CTs, head CTs using AI. We have FDA CE cleared products. We're cleared in about close to 90 countries, and we are today deployed in about 70 countries, in about close to maybe around 1,000 hospitals across the world, across the 70 countries. And on an annual basis, we probably process upwards of about 5 million scans. So that is where we are. And we, again, we started out of India. Now we have entities in US and UK. I'm currently in London. But again, fairly global in terms of our go-to-market and reach.
Prashant, I just want to hone just a little bit on this before we get into it, because obviously, for folks who are listening, you threw a lot of information in 1 minute. When you say AI focus on interpreting scans, are we getting rid of Saurabh, or are we just enhancing his ability to interpret scans? Like, what do you mean by that?
No. So only enhancing, only augmenting radiologists, right? But I think what we'll talk about today is in places like Nepal or places like rural parts of India, lots of Africa, Southeast Asia, there are no radiologists available to read the scans. So we are actually augmenting a physician there, a general practitioner who's forced to read that scan. Sometimes even not even a general practitioner, could be a healthcare worker who is doing that. So again, that augmentation becomes a lot more valuable in that kind of a scenario where you don't have a trained radiologist available. And in many places, for example, especially for tuberculosis screening, which is tuberculosis is still very prevalent in most of the developing countries. There's still more than 10 million people who suffer from TB every year. India is the largest, has the largest burden of TB. And for that particular capability, detecting TB on a chest X-ray, we actually got a WHO recommendation where they said that AI can be used autonomously as a replacement to a human reader. So that is one place which we have seen that you can autonomously report scans. And that is mainly because the places where we are reading those scans are basically, there is no radiologist available. It just...
That's amazing. And then the company is privately held at the present time?
It's privately held, yeah.
Privately held. Saurabh, how did you get to meet Prashant and get to know about his work? Was that through your British connections, Indian connections, or radiology connections, or all of the above?
Yeah, first I do know, Charlie, you're very keen to have me request. I mean, what do you think I'll be doing if I'm not reading scans? You should be worried.
I'm actually, no, I was very nervous. I wanted to
Yeah.
make sure. I was extremely terrified of the idea
You're
that you have
having me replaced.
you
Find
having
something
more
else.
free time on your hand is really dangerous.
Yeah, so actually I met Prashant through, believe it or not, Twitter. So as we've come to dislike this medium, it does open channels. And I found their TB platform quite intriguing because TB is something that's a very intriguing disease. You know, it's been around for a while, it's killed loads of people, but we still haven't managed to get rid of it. And despite all the efforts, and there are reasons for that. One of the big reasons being that in order to get rid of it, you need to diagnose it. And in order to diagnose it, you need to diagnose latent TB, which was initially done with X-rays. And then for some reason, the WHO said, oh, you know, you radiologists, you're disagreeing with each other with a huge inter-observer variability, and they stuck to sputum. And then they realized that people don't like producing sputum. Sputum is not something that you want to cough up that easily. So they went back to X-rays. Then, you know, we faced a different problem. You had the X-rays, but who's going to read them? So it's very intriguing that the AI ended up providing this public health solution. And it's intriguing at multiple levels. I mean, there's, of course, the greater good element of it. But when AI first came out, when we first came into our conscience, was around 2014, 2015, when Geoffrey Hinton famously said that it would replace radiologists, so there was no point training radiologists. And Vinod Khosla speculated that it would replace 80% of doctors. So there was a lot of money from Silicon Valley and venture capitalism in this space. Yet, what's ironic is that it's the public health, it's the infectious disease, it's all these organizations like USAID and Gates Foundation, and the drive to eradicate TB that has led to the development of AI. So I don't know if Prashant would agree, but it would be fair to say that your company has grown more from the needs of the poor to the whims of the rich. Would that be correct?
No, absolutely, absolutely. I mean, I'll also give our storyline there, right? I mean, when we started, we thought our markets would be US, UK, Europe, and these are the markets where we would find more usage of our solution because, again, those are the markets where you adopt newer technologies, adopt the cutting edge technologies. But when we started working on, I mean, go-to-market, when we started going to customers with our solution, we found that the biggest opportunities, in fact, I mean, when we met the Health Secretary of India, who's basically one level below the Health Minister of India, he said that you should basically look at TB because this is a massive problem for India. And if you can solve anything on that, that could be extremely, extremely valuable. And it sort of, I mean, when we started when we started in 2016, for the first 1.5, 2 years, we never thought that that would be a market that we'd cater to. But then we realized that there is a massive opportunity because, see, I mean, the quality of care, I mean, in UK or US or continental Europe is pretty good. And you have radiologists for reading scans. You are able to get scans interpreted on time. Again, there could be a lot of improvement there, but still there is that quality radiology available in these countries versus a country like, let's say, countries in Africa or let's say Indonesia, India, Vietnam, and so on, where you don't have in India. It's very hard to find a radiologist in some of the smaller towns. I mean, India has like what, maybe 12,000, 13,000 radiologists for a population of 1.3 billion people. US has 1/4 of our population. You have got, I think, about 40, 50,000 radiologists. So,
I am intrigued by the statistics of TB, actually. I did not know that this is how common it is still in 2022, 2023. But Prashant, were you able to generate data that you published that demonstrate that your solutions have A, improved the diagnosis, and B, maybe improved the outcomes?
absolutely. So I think we have shown that we are able to improve many things. I'll talk about some of the different things, right? One is that the basic baseline study, which shows that you are compared to a human reader and you are better than a human human reader identifying TB on a chest X-ray. See, again, TB is a diagnosis in many ways, right? It's not a finding. I mean, what you're looking for is consolidations, cavities, some nodules, nodular patterns. And I'm not a radiologist myself. I just learned all these things. I'm a data scientist. But you have got all these patterns on the X-ray, and based upon that, you are creating an inference of TB, right? And a lot of radiologists may not even be trained enough to understand what TB looks like on a chest X-ray, especially because it's not so prevalent in many places, right? So one thing we showed that we are actually typically better than human readers at detecting TB on a chest X-ray. And this is studies conducted by a lot of folks from Stop TB Partnership, which is a Geneva-based organization funded by the UN, to McGill University, which is one of the top infectious disease organizations, infectious disease universities in the world. So all of these guys have done studies which show that our technology is better than human readers, number one. Number two, I think the most important thing is that it's significantly faster, because one of our customers, first paying customer at Qure, was this mobile van screening program in Philippines. And so they used to take a mobile van which has an X-ray unit inside the van, and they used to start from Manila, and they used to go around, travel around Philippines, screening people on a daily basis. So every day they might screen about 200 people, and they had 4 such vans. So they had 4 vans, and they don't have a radiologist, they don't even have a doctor in the van, right? So what used to happen is they used to travel around for a couple of weeks, and the X-rays used to come back to Manila. They used to consolidate all of them and then send it to a radiologist for interpretation. All that took about 3-4 weeks, sometimes 5 weeks. And you're talking about a patient who got an X-ray for TB, getting an interpretation 4-5 weeks from when they took that X-ray. And with our technology, they were able to make that happen within minutes at that time. Now it is within seconds. We can do it actually within 10 seconds. So within 10 seconds, as soon as the X-ray is taken, within 10 seconds, we can say there is a risk of TB. And X-ray is not a confirmatory diagnostic for TB. You're basically going to do a sputum test, what Saurabh said, right? That it's basically what is called either a gene expert or a mall bio. There are multiple companies which manufacture those tests, but you basically do a sputum test. So now what we can do is you can, rather than waiting 4-5 weeks, you're able to now do that test at that point of care right then. And that radically changes the diagnostic protocol, because a lot of people fall off the radar. I mean, they don't come back. And so that is the other improvement that we were able to see, is that number of people who got diagnosed increased by 40% across multiple programs, because we're able to diagnose them at the point of care.
So Rob, have you seen other applications outside of TB so far? It seems like the TB story is pretty compelling, and I believe you actually wrote a couple of blogs on this, which I found very, very informative a while back. Have you seen other applications outside of that?
Well, I think, when you think about AI and imaging, the first thing that you have to disabuse the notion of is that it's somehow a first world technology. I mean, in many ways, it is a technology that is the kind of, some product of all developed world technologies, but its major use is in areas where you have constrained resources. So to give you the example of of Everest, one particular diagnostic dilemma that their physicians or any healthcare providers face at, say, altitudes of 17,000 or 18,000 feet is the distinction between pneumonia and pulmonary edema. Because of high altitude, you can get a condition called high altitude pulmonary edema. And because the air is thin and you get thick secretions, you can get what's known as the Khumbu cough. Khumbu refers to the area there, and those secretions, as you know, can be nidus for infection. So, when you have that kind of dilemma over here, which is also a diagnostic dilemma, I don't know, the last time you percussed, I don't think it's a terribly useful clinical distinction. I think Adam Sithu might disagree and get angry with me, but I
do that every day.
Yeah, I'm sure you do. Yeah. So here, what you'd do is you'd empirically treat them for both. You'd give them maybe a diuretic or a calcium channel blocker and put them on a broad spectrum antibiotic. You can do that there as well, but there is one big distinction, because anybody who has high altitude pulmonary edema will die if they don't descend. So there's nothing you can do at that level. You can give them oxygen to stabilize them, but ultimately they need to descend. Now that again seems to be a fairly, okay, they descend. What's the big deal? You descend from 5,000 meters to 4,000 meters. Firstly, the distances are long. Sometimes high altitude pulmonary edema can strike at night, which makes the journey more difficult. But the last problem is a kind of a cultural / economic problem. We think of health equity, but this is like pure application of health inequity. So one of the doctors from the Himalayan Rescue Association was saying that if he has a diagnostic dilemma between pneumonia and pulmonary edema, and the person is a tourist, a trekker from Europe or from North America, he will have no qualms calling the helicopter rescue service to take them. It's like, I'm not going to risk it. It's no big shit for this. But I mean, in terms of the decision making is very simple. But if it's a Nepalese porter and you say you need to descend when it's just the Khumbu cough or pneumonia, then you're pretty much depriving them of their livelihood. And so what happens is they're more reluctant to make the diagnosis of high altitude pulmonary edema, HAPE, in the Nepalese porter. As a result, they do reduce the false positives, but they have some, pretty bad false negatives. Yeah. So a lot of the deaths in that group happens because somebody was being overcautious on the other extreme. And that is where an X-ray, something as simple as an X-ray that we kind of, rubbish over here because it's done every 6 hours to see where the NG tube is vital. So then what's the role of AI? Well, I think that when you're making such dramatic decisions, and these are really high-stake decisions. This is not the decision between, should I send you home or should I send you to the observation unit? This is, should I screw your livelihood up, or should I keep you over here and treat you empirically? The AI assistance, and this is what we found, the AI assistance gives them that slight confidence edge that makes all the difference. So I would say that AI, I don't know commercially where it's most useful, but in terms of its actual, its actual value, just pure value to people who treat people in extremis, it's in those places at altitudes of 17,000, 18,000 feet.
That's really amazing in terms of trying to differentiate between two diagnoses, but one of them could screw your livelihood, like you said. That is a powerful statement. Let me step back. And how did this trip come about? I mean, I woke up one day and I was scrolling through Twitter and I saw pictures of you guys on mountains. And aside from the beauty of these mountains, how did this come about? Why did you start in Nepal versus some other country, obviously? And what was the purpose and how did you plan it? It seems like there's so much you have to arrange and plan and all of these things. Who can take this on? Just explain to me like I'm a fourth grader.
I'll have to take this on, but Prashant can add, because
go ahead.
The trip was done very impulsively. We were on a Zoom conversation in February. We were having tea. We said, lads, do you want to come over to Everest Base Camp with me? I was already going there with my son, dad-son bonding trip. And I was going to visit some hospitals over there. I said, you guys come along. And the great thing about working with companies that don't have huge bureaucratic infrastructures is you can go to their CEO and say, you guys want to come along? And Prashant's like, yeah, we'll come along. He just asked me, how fit do I need to be? I said, Prashant, if I can make it, you can make it. I'm pretty sure that you are fitter than me. So it was done very impulsively. And I think it was done with a purpose. Even though it was impulsive, it was done with a purpose. I think the idea was that the idea all of us had, Michael is not here from MinX-Ray, but the idea all of us had was, we want to show that it can be done. That you can take an X-ray to the frontiers of wilderness. My motivation was to make radiologists seem sexier and more relevant. I'm not sure about the more relevant bit, but I'm pretty sure that I made them seem sexier.
For sure. No, for sure. Some of your Photoshop pictures were there. But the idea was, so the idea was you want to be able to You were going to Nepal and you wanted to demonstrate that you can do these X-rays fast enough, accurate enough to be able to differentiate between these two major diagnoses.
And also, in further enough in the field. I mean, a lot of times what you see is that people concentrate on big cities like Kathmandu, which have the infrastructure. But can you push the boundaries? Can you go higher up? Can you go where things are sparser? And that was the idea. And personally, I've hiked in Nepal and Tibet a lot when I was in my youth, and also more recently. So for me, I really love the Sherpas and the people out there. They're very nice people. And Prashant also agrees. Some of the kindest, most loyal people, these Sherpas, you just feel good helping them out.
So Prashant, then you guys planned the trip before you went there. Did you map which clinics you're going to see, the doctors you're going to talk to, the hospitals, the like how, or was it very spontaneous even there? Let's just go up there and just see the people.
So I think I mean, one thing is that Saurabh did a lot of groundwork. He spoke to several people, the Himalayan Rescue Association. There is the Mountain Medical Institute. Many people that he already connected to. He was connected to a radiologist in Kathmandu, one of the top radiologists in the country. He was connected to him, and through him he got access to a lot of people. So we had access to a lot of radiologists and doctors in the region, in the Khumbu region and in Nepal. But again, it was something where we also did not know how far we could make it. Could we make it all the way to the base camp? Could we make it to all the different hospitals on route to the base camp? So again, it was something that we took it on the fly. We said, okay, we'll start from Lukla. So we basically go to Kathmandu. From Kathmandu, you can either fly or take a helicopter to Lukla, and that is where you start walking towards the Everest and towards the Everest base camp. And it's about, if you want to walk up and down, it's about a 10-day trip. And we only had about, I think, maybe 6 days. So we walked up and we took a helicopter back down. But the reality is, I mean, we were also thinking about how we can go to all these places. We didn't even know what the facilities would be like. I mean, one of the things we realized when we went up there is that in this place called Namchi Bazaar, which is sort of the base camp to the base camp, which is in between, halfway between Lukla and the base camp. There is a hospital there, like a very small clinic there, but they don't have any imaging facilities. They don't have a X-ray or a ultrasound or anything of that sort. We went to this place called Ferushe, which is an altitude about 4,400 meters or so. And there again, I mean, they have a small clinic and with one doctor and one paramedic, but no imaging facilities. So what we did actually is that's where Michael comes in. He's not here today, but he's the sales lead for this company called Main X-Ray, and they have these backpack X-rays. So that was a 24-kilo X-ray which can fit into your backpack, and we didn't have to carry it. Fortunately, there was a porter who was with us who was carrying that X-ray machine. But we took that X-ray machine, and interestingly, I mean, we found so many things. I mean, we were able to, in Namchi Bazaar, we found this lady who had they were not sure whether she had a fracture or not. So because they could not image her, and we actually imaged. We took the X-ray. We found that it was not a fracture. She had fallen down maybe about 4 days ago. So she was in pain for last several days, but no diagnosis, because I mean, if she has to get diagnosed, she has to walk all the way back to Lukla, which is a 1.5-2 day walk. So which she cannot do in that condition, or she has to take a helicopter down, which she cannot afford. So it's almost, I mean, like with that imaging support that we provided, we were able to help her get diagnosed at that point of time, right? We found one of our people who was carrying our bags, I mean, our porter, we found that he had TB in the past, and we found that there were signs of tuberculosis, healed tuberculosis, not active tuberculosis, but healed tuberculosis on his X-ray. We found, I mean, Saurabh actually diagnosed somebody with high altitude pulmonary edema at the hospital in Namchi Bazaar. He met that patient. That was again a porter who actually had climbed up very fast, and he developed HAPE, and then we were able to image him, get his X-ray, diagnose him. So it was very, very interesting, because for that, I mean, that's a region of maybe about 300-400 kilometers, pretty big area, right? And you have maybe 1 or 2 doctors, obviously no radiologists, no imaging facilities, and only the most important thing to understand is that you cannot take a car or anything down. I mean, the only way down is helicopter or walking, and helicopter is not affordable for most people of that region. I mean, of course, for tourists like us.
This is just listening to this, makes you think how fortunate we are where we are right now. And B, I can't imagine how they do what they do.
Bless you.
Yeah, I really can't imagine. I mean, because one element is the diagnosis. So let's say, Saurabh, you diagnose that lady with a fracture. Then what? I mean, how she's gonna get? How can she get the helicopter? Who's gonna do the surgery? Like, I think there's a trickle down effect after the diagnosis that is still impossible to account for. No?
Yeah, so the thing is that anybody that has something that requires surgical or high level of medical therapy needs to be taken away from the mountains to Kathmandu, which is the nearest place. And that there are ways that they can do that. One of the ways is that there are a lot of helicopters coming in and out, bringing supplies and taking the richer tourists away who can't be bothered to hike all the way down. So they've developed a scheme, a kind of a honor scheme, where if they have space, they'll take one sick person with them. There are also flights coming out of Lukla, which is the world's most dangerous airport, by the way.
Why is that? Why is it the most dangerous?
Because it's all instrument. I mean, and also it has a very short takeoff and landing stall, and apparently it's downward sloping. And if you miss time, then the only way is up, and that's up to heaven, that is. So it's a pretty dangerous place. And so that bit you can't avoid. But where imaging comes in is that you don't want somebody to be frivolously taken to Kathmandu if they don't need to be. So it's the reduction in false positives where I think it's most valuable. It doesn't solve the infrastructure issue, and in some ways it can't. I mean, you can't have neurosurgeons in Namche Bazaar because you just don't have the economic model for that, at least not yet. Yeah. What you can do is you can make sure that nobody gets transported to the neurosurgeon when they don't need to. And it's the idea of medicine in remote areas needs technology. I mean, that's the kind of irony of it all, that technology is most needed in the remotest areas. And I have to give credit, and I know he hasn't been doing a good job with Twitter, to Elon Musk. The reason why you can have this type of technology in the Everest region is because of his internet provision. I think, what is it called? Starlink or something like that. Yeah. So you've got this infrastructure that is that doesn't require buildings, that doesn't require a lot of human resources. That is absolutely vital for getting for helping some access. It's not going to be, you know, if you're at base camp and you've got a perf viscus that requires a laparotomy, you need to be evacuated. I mean, there's no heroic surgeon there. The question is, you don't want to make that diagnosis incorrectly.
Right. No, absolutely. I got that. And we can disagree on Musk. I think Musk is going to be great, actually, for Twitter and everything else. I'm on team Elon Musk, but we're not going to go there. But Prashant, I'm trying to put my business hat, and in order for you to have a thriving company that makes money for your shareholders and for you, and to be able to get all of the costs, you have to have a business model, and it can't be always charity. So is your idea that you're going to be able to sell that technology to these poor areas? Because I can't imagine they can afford buying it. So I'm struggling with, you have a great technology. It's clearly working in certain areas, but if your business model is going to the poorest of the poor, you're not going to be able to make money.
No, so several things there. One is that this is only one part of our portfolio. We have solutions for lung cancer. We do detect lung cancer early on chest x-rays. We have a chest CT product, which is again focused on lung cancer. We have an application full end-to-end diagnostic workflow for lung cancer, which is again being used at the NHS. In fact, I mean, I have meetings with NHS here right now in London to discuss this, right? So this is being used by the NHS. It is being used by AstraZeneca for detecting lung cancer early because, again, getting patients towards therapy faster and sooner. And one of the ways to do that is by looking at the X-ray, which was taken for routine reasons. So you've got 1.3 billion chest X-rays taken every year around the world for routine reasons. And if you can identify an incidental nodule on that, and then we also actually classify that nodule with a malignancy risk, you can triage those patients and get them a CT. So that is what we're doing across the world now. We are working with AstraZeneca, we're working with NHS. We're starting to work with some US hospitals also on this. So lung cancer is an area that is a big focus for us in some of the developed countries. Stroke and trauma is a focus for us. So we look at head CTs, detect bleeds, infarcts, midline shifts, mass effects, many things on the non-contrast head CT scan. So again, that is a area. Triaging those critical findings is another area for us. So and then on chest X-rays, we do practically everything. So we, in fact, one of the things we do with many groups now is, especially teleradiology groups, is they read about anywhere between 1,000 to 10,000 X-rays per day. And what we are able to tell them is, out of those, about 60-70% are normal X-rays, what are called unremarkable X-rays. And we are able to say that these are the unremarkable X-rays, and you may not necessarily need to spend that much time on these X-rays. You focus your time on what is the abnormal X-rays. So again, that's a use case for our product. So again, we are a fairly broad portfolio company. The TB and some of these are unique capabilities that we have. But again, I would also want to add that don't assume that these people don't have the money to pay. The reality is that people can pay, and either they pay, sometimes there is developmental funding, like Saurabh mentioned, USAID or a Gates Foundation, or governments are interested in paying for this, right? Governments want to deploy, they want to get care to the people who are voting for them, right? So there is definitely interest in paying for this technology, and maybe the amount of payment might be lower than what you would expect in a US or UK, but it's still good enough. And for a technology which is running automatically on a cloud service, that works out well for us. I mean, it's not that that is an unprofitable business for us.
Saurabh, what else did you notice on this trip? We talked about the pulmonary edema and the obviously the pneumonia, which is a big deal. What else did you observe in terms of during that trip as you saw patients? And you said one of the things that you would love to see happen is show the importance of diagnostic radiology even in these underserved areas. Any observations?
Broadly speaking, I think what the major observation was that if you lack lots and lots of diagnostic facilities, you end up creating clinicians that are very orthodox, old school, relying on H&P. And one of them was this chap in Namche Bazaar. His name is Abhiyu Himari. And young guy, and really very impressive guy. And he is the only doctor in Namche Bazaar, and he doesn't have an X-ray. He has an ultrasound machine, but he told me that he doesn't know how to use it. And ultrasound is another modality that can really help in that area. So what has happened with this guy, Abhiyu Himari, is that he has hypertrophied his clinical acumen by virtue of the fact that he doesn't have any diagnostics except for basic blood tests. He approaches things in a very pragmatic manner, and so he treats appendicitis with antibiotics using what I think is the Helsinki protocol or something like that, because he thinks that he thinks that it's not just my responsibility for the patient; it's my responsibility for the pilot that comes to rescue the patient. And so the doctors there are phenomenal. A lot of them come out straight from their medical school. So what happens in a lot of medical schools in Nepal, if the education is free, they must do some time in rural areas for about a year to 18 months. And these guys come in with a immense sense of pragmatism on how to deal with stuff. So, yeah, as much as diagnostic imaging is necessary in this part of the world, what is admirable, and particularly for me, because I started my career not in radiology, in surgery, and not with much diagnostics at my disposal either, is their adaptability to that situation, and that's seemed to be that one of the most impressive things on the trip.
Yeah, it's really fascinating to me, and I wanna Saurabh, stay with you just a little bit, because one of the things that intrigue me whenever I see something like this is the training of future residents and students, and you know, you work in a center where you training is part of it and educating is part of it, and I think the current trainees they're not really exposed to the ability to make these diagnoses and diagnostic abilities with limited information. I mean, they feel like they can, sure, get a PET scan, get an echo, get a blah blah, and get 5 tests, and then, you know, I mean, sometimes a monkey could make the diagnosis if you have all of these tests available. Do you feel that there's an opportunity to retrain some of our students and residents to be more astute and to go back to sometimes the chest X-ray and the stethoscope and things like that?
I think it would be a good intellectual exercise. I think most people would argue that in the American system, it's almost pointless, where the skill that you need over here is a different one altogether, where you have to manage multiple sources of information and distill an answer based on that. Instead of working in limited information, you now have too much information, and that too much information can lead to analysis by paralysis. So and to be fair, people like Dr. Abhiu in Namche, they're rare even in low middle income countries, where there is a tendency to having imaging confirmation for before they go for a laparotomy. I mean, from what I hear, that even in India and Nepal, people are reluctant to do appendectomies without some form of imaging confirmation, sonographic or CT. So you know, so it's kind of, you know, it's bucolic, it's impressive. I do think that if you are, I do think that we need to create a field in radiology, a subfield that is, where you learn to deal with constrained environments. But let me just bring one thing back. I think one of the things that people who haven't worked in constrained environments don't realize, it's not so much that you become good with percussion. It's not so much that you suddenly, when you auscultate, you hear basal crepitations and the second splitting of the heart sound. It's that you know that you have to make a decision, and you learn to make decisions. So this guy in Namche was making decisions, and he was doing it rapidly. Like, he was doing it within 20, 30 minutes. I remember he had one patient who came in with what seemed to be a fairly classic case of disc protrusion, acute disc protrusion. He made that diagnosis within 30 seconds, and he gave her a treatment plan. And I think that's where what imaging can have a positive and negative effect. Once you start having that reliance on imaging, which definitely helps, and I think it'll help in the net, you'll lose some of that decision-making, decisiveness or
other. Prashant, you know, when you look at the globe, I guess, what areas in the under-resourced countries do you would like to go outside of India and Nepal? That's one question. And then these countries are very often there's some level of corruption we all know exists, and politics interfere with everything. you have to deal with them sometimes to be able to get access to certain things. How do you do that without losing your mind?
Yeah, so one thing which I mentioned this early, we are in about 70 countries now, actually more than 70 countries.
But what do you mean by that? We're in about 70 countries.
We
You
are
mean like
deployed and used actively in clinical care in 70 countries.
in one hospital in one country, or
some countries might have 2-3 hospitals, some countries will have 200 hospitals.
and how big is your company right now? Like how many people?
We have 200 people.
Seems like you need double that with that many countries.
So it's
Okay.
an AI company. It's an AI. So it doesn't matter how many people we serve. It's all going to a server. Results are coming back.
No, I get it.
Scalability,
Okay.
right?
So you said 70
Scalability.
countries. That's amazing. Okay.
So, and these are, we are in maybe like 15 African countries. We are in practically all of South Asia and Southeast Asia, including Pakistan, and Bangladesh, and Nepal, and of course all of Vietnam, Philippines, Indonesia, and we are in tiny countries like Papua New Guinea or Timor-Leste, and Fiji, and so on. So again, why we are there, I'll talk about how we get there, is because there is a lot of philanthropic funding for TB, and we are able to work with the organizations that are creating those funding programs and work with them to get to those countries. So in that way, we are able to bypass some of the corruption, because while you're right that it's, working with the government in any country, even developed countries, is typically very difficult. It's a long process. And with corruption, it becomes even harder, right? But what we are able to do is working with a lot of the NGOs and the philanthropic funding, we are able to get to more locations easily with the support of those organizations.
Yeah.
So that is what we are doing. And again, our sort of go-to-market is fairly global. We've got people who are focused on the emerging markets, people who are focused on Africa. So we are also reaching out to those countries. And every country, every one of these African countries, every one of the Southeast Asian countries will have a national TV program. So we engage with them and work with them.
You mentioned, like, for example, the machine that was carried up to the mountain. Is the idea is to leave these machines there? Like, and just train people to use the machines, because you still have to have the machine there. That's going to help them interpretation. Are you making enough and you'd like to deploy those?
We would. So, again, we are not an X-ray machine manufacturer, so it is not our call to give it out. Michael from MinX-Ray is the manufacturer, but we are looking at funding to be able to grant out some machines to that region, the Khumbu region. And a machine costs like 40-50K.
Yeah.
And so if you have 100K budget, you could basically give out 2 machines.
Two machines.
One to Bazaar, one to Ferishe, right?
So, Saurabh, you've been involved in AI since the day I met you. For the contrarians against AI, because they exist, what do you see the biggest pushback from people who say AI is overrated, AI, blah, 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 or they even question sometimes how we define AI? In your line of work, have you gotten a lot of pushback into the application of AI in diagnostic radiology? And if so, what are these elements that they can test against?
I think, any technology is going to be overrated if it overpromises. So it depends on what AI seeks to do. And when the buzz first came out, which certainly got my interest, it was making a promise, it was making a generalization that really was just too fanciful. The reality is the human body is complex, and we say that all the time, and imaging is complex, but there are areas of simplicity within the imaging. For example, the most complex part of imaging is the abdomen pelvis, where the bowel and the spleen, and for algorithms to solve that, that's like the final frontier. Kind of ironic, isn't it, that the large bowel is the final frontier, whereas the brain is the low-lying fruit. You would have thought it would be the opposite. So nature plays a joke with us. I think that if you have to frame any technology correctly, if you frame it as an enabler, that's useful. You're not going to get much pushback. If you frame it as, radiologists are working at breakneck speeds, which we are, believe it or not, even though you can't tell from my countenance. And if we just pull you back from the abyss, your lives will be easier. I think that's really where the focus should be. The contrarian rises like the phoenix when tall claims are made. And in all fairness, I mean, Prashant, I've known for a while, hasn't made any tall claims. I mean, his claims have been rather industrial. Like, we're just going to tell you normal and abnormal consolidation or cavities. And to give you an example of where simplicity and simple claims works, I think as Prashant mentioned, there was a chap on our team, one of the Sherpas. He was, I think, the fittest. So
you were not the fittest, Saurabh?
I was just going to say that if you created a fitness scale and had to put me in it, you'd have to create a logarithmic scale. I was the slowest in the group. Even my son was exasperated by me, by my slowness. I was an embarrassment. And my O2 sats at Fariche was 76%.
Which is actually about 10 times more than what I would have expected.
What you expected. I mean, if an ER physician was there, I would have been intubated instantly.
Yeah.
So this guy was very, very fit. And he also volunteered like all the others. They didn't just volunteer, they said, I want to have an x-ray. And we ran his x-ray through AI, and just as other x-rays had been run, it was like normal. And I just checked them and made sure that I agreed with the AI. I was like, yeah, agree. TB. Like, oh shit. Because you know, when somebody says TB, it's like this big burden on your head, because now you have to say, well, you might have TB, you need to go and see a center, then you have to report. It's just a pain in the ass. And then he laughs. He says, yeah, I had TB 10 years ago. And as a result of that TB, he couldn't apply for a job in Dubai. But it just tells you the simplicity of AI. The beauty lies in simplicity. Is this guy is walking around, he had TB, he forgot about it, everybody else forgot about it, and it gets picked up. Yeah. And so long as we, at least for the foreseeable future, stick to simple things, like, even with the head trauma, the question is simple. Is there a bleed that requires neurosurgical intervention? We're not going complex. We're not saying, is this amyloid or is this a neurocysticercosis or something like that? Is it a bleed? Simplicity is often underrated by diagnosticians. I think we want to go for the kill, but some of our most basic questions are really very industrial questions, and AI can definitely help there.
I mean, the return on investment when it comes to these low-hanging fruits in terms of the type of questions we're asking is amazing, because they are so important, they're so practical, and you provide these examples. The bleed versus not bleed, the pneumonia versus the pulmonary edema. Yeah, I do get concerned, and that's probably the last part of the podcast or the segment. I do get concerned about the screening part. I think screening is such a hotly debated topic. My goodness, there are people that are probably going to go to war against each other about screening. And then you bring AI into the mix of screening, which for all practical purposes, I would buy. Here's what I would like AI to resolve for me when it comes to screening. If we decide on screening to start with, I want AI to tell me whatever I pick up is something worth pursuing or not. Now, as you know, there are many people out there who say screening should not be done, period. Even colonoscopy should not be done. Mammogram should not be done. PSA should not be done. But that's for a different topic. I think if we decide that screening is being done and you pick up a lung nodule on a spiral CT scan, I want your technology, Prashant, to tell me ignore or go ahead and refer for a biopsy. Can you do that?
So we can do that. I mean, see, theoretically, we can do that. But the reality is that from a regulatory perspective, we are only, I mean, if you look at US, Europe markets, right? We are only an assistive tool for a radiologist or for maybe a pulmonologist or an oncologist, right? But we can do that. We can say this is a nodule, this is likely malignant, you should do a biopsy. Certainly we can tell you that. But then the final call has to be taken by a physician. We cannot, AI at this point is not authorized to take that call. And that's almost like autonomous vehicles, right? I mean, you can theoretically have autonomous vehicles. I mean, a Tesla could do a lot of your work for you, but you still have to be in the driver's seat. And it's, I mean, again, the different fields, I mean, comparison is not exact. I mean, so obviously, even, I mean, the tasks that we are trying to solve require so much more skill than driving, right? I mean, this is something that takes 30 years of training. You have to be 30. I mean, anybody who becomes a radiologist is already about 30, right? So it's something which requires a lot of training. But the idea is that it's not autonomous. It is not allowed to be autonomous, but it can take those calls. It can help a radiologist take those calls that this is potentially malignant. This is not, you should recommend a biopsy. On an X-ray, it can tell you that this is potentially a malignant nodule. You should go and do a CT. So it can create those pathways. And that is why it is very useful. AI is useful because it scales, right? I can basically run this algorithm on every X-ray that is taken anywhere in the world. I could run it on every CT taken, and I could basically do that just by scaling up the servers on the back end, right? And it's highly scalable, number one. Number two, it's very fast. The reality is that you can now run a scan within seconds, within minutes. So if you have this patient with a bleed or an infarct, and you can within a minute identify that this patient needs surgery or needs a thrombectomy or a thrombolysis, I mean, rule out a bleed for thrombolysis, you can do all of that within a minute. And that changes the protocol for that patient. So think about the speed. Think about the fact that it's scalable and it can be on every device, on every scan, so that it can help alert and help radiologists become better. So those are, I think, two areas where it can be really very useful.
So, Rob, do you worry about AI in screening from where you sit?
No, I think I know what you're asking about the lung nodule. And essentially, in ROC terms, sensitivity is scalable. Specificity, it's more nuanced. Specificity varies from individual to individual, from indication to indication. So sensitivity is the low-lying fruit, just picking stuff up. So in terms of your wish list, I think AI is delivering the opposite, which is it's being extremely sensitive and leaving others to sort out the specificity. And I think that's kind of a diplomatic kind of ending, or rather diplomatic agreement, where my job is not to hunt for a needle in a haystack, but rather to give those needles that I've found in haystacks some meaning. And I'd be happy with that. And also with regards to screening, you know, you've got screening for TB and you've got screening for colonoscopy. The thing to appreciate about TB is that if you want TB to be eradicated, which the WHO does want it to be eradicated, it becomes like a zero event. When anything is a zero event, as you know from your quality and safety days, you have to throw the kitchen sink at it. Because, you know, it's why the zero COVID guys they'll never win, because it's just going to be so much more difficult. But TB is slightly different in that regard. It's been there for longer. So in that regard, in order to pursue a zero TB policy, which is what WHO wants by the end of 2035, you need to maximize your sensitivity and have specificity around the corner. And for that purpose, I think AI is absolutely perfect. It's as if it was invented for that particular region. I mean, if you want to say who should we credit for AI, it's not Vinod Khosla, it's Mycobacterium tuberculosis.
Wow. Well, before I let you go, Prashant, two questions, and then A, anything you would like to say that I may have forgotten to ask you, and B, where do you like to see your company in 5 years?
No, I think I covered. I think we covered most of the things we want to speak about. So definitely, thanks for inviting me here. Thanks for all the very good questions about our trip and what we do as a company. In 5 years, I mean, see, I think I tell everybody that we want to be a unicorn in terms of number of lives touched. We want to touch 1 billion lives, and that is our goal. And 5 years, I don't know if we'll reach there in 5 years, but that is what we want to get to. And hopefully we get there in 5 years. So today we are, yeah, I'll just pause there.
Saurabh, anything I forgot to ask you that you would like to comment on, and where's your next trip?
Yeah, actually, Prashant, now that you're here, I've got your attention. We need to chat about our next trip. No,
Actually, I like that. Let's decide on the next trip on the Healthcare Unfiltered podcast. That would be great because I get more clicks. I get more clicks.
Are you coming, Chari? Do you want to come to?
I am. If you you know how Saurabh's saturation was 76%. If you divide that by half, that would be my saturation.
Yeah, I do want to make one point, Chadi. I think one of the things that was great about our trip, which was called Project Khumbu, was that it was like a unique alliance between multiple people. So there was me, there's Min X-ray, Qure, a lot of Nepalese physicians were also involved, local physicians. And so if you want to do something in low middle income countries, you need a partnership. And that's kind of, like that's not a terribly insightful thing to say, but it's something that is often forgotten. I mean, people go to these places and they want to take selfies and Instagrams, and that's all well and good. But if you want to achieve anything, you can't do that without getting stakeholders. And you certainly can't do that without tech. Tech is crucial. And tech gets a very bad name because of the whole farmer relationships, and people get into their frenzy about that. But in reality, it's a partnership, and that we're kind of all on the same team. I know that's a cliche as well. We're all on the same team, and I think what we've demonstrated here is how to do this partnership, how to combine people from academia to people from government to industry, and to their local physicians. I mean, we're all very instrumental. We even actually had a cameraman from Kashmir join us, and he had a great time as well. So it was a great trip. I hope to do it again.
No, that's good. And Prashant, we can plan a trip to Syria or to Dubai, and I will go for sure. I can arrange for you to meet a lot of physicians and hospitals, and we can all agree that it is under-resourced country. Dubai, I'm not really sure, but I mean, it's over-resourced country, probably Dubai as a city, or the UAE, but yeah, it is something to discuss. So I'm looking for. I can go to the Middle East.
We should do it in Syria. Absolutely.
I'm more than happy to help arranging this. I'm serious.
Yeah.
And one good thing about the algorithm is that Jihadi John can't decapitate it.
Well, the good news actually in Syria, Saurabh's saturation will be okay. It's not really, we'll take care of him there. Well, folks, thank you so much. This is really great. I really appreciate. For context, we are actually taping this on a Sunday morning, and part of this is Saurabh and I have no lives, so we really have nothing to do on Sunday, while Prashant is in London somewhere, and let's see who Manchester United is going to play today. Thank you so much, guys.
Thank you.
Thank you.